everyone. Welcome to the GHAPP MASLD Community Network meeting. My name is Taylor and I'll be your moderator. I'm joined here virtually by our presenter, Anthony Derencius. There will be an opportunity to ask questions live at the end, so please hold them till then, and I'll turn it over to you, Anthony.
Thank you so much. So I'm excited to talk to everyone this afternoon. Let's get going. So we're going to be discussing kind of a case-based concept of MASLD or MASLD pharmacotherapy. As introduced, I'm Anthony Derencius. I'm a physician assistant and sub-investigator at Pinnacle Clinical Research, and I definitely manage in the realm of clinical research, deal with a lot of MASLD and MASH. So from a clinical standpoint, clinical medicine more than clinical research, we know there are some available treatments for dysmetabolic management or treatment of the metabolic syndrome. And when we talk about, MASLD, MASH, we know that this is not just as the circle here shows you, it's just a small proportion of what our outcome and our goals should be. So we want to look at the patient as holistically. We want to look at their obesity risk, their cardiovascular disease risk, kidney risk, let's say, and then liver as well. So kind of the main three components of how we manage both metabolic syndrome and then in the setting of liver disease is we can look at it as far as weight loss, treating underlying conditions like diabetes, maybe hyperlipidemia, their cardiovascular risk factors, and then we'll talk also about specifically liver-directed treatment. But just to start off with weight loss, we know that weight loss can treat and cure even MASLD and MASH. Weight loss is going to have to be definitely a change in lifestyle, both dietary, nutrition, physical activity, and that was discussed at maybe another presentation. There are definitely weight loss medications on the market, different classes, different indications. We know that surgical weight loss through different types of bariatric surgery is very effective and a good treatment for obesity as well as the metabolic syndrome. And then kind of crossing the lines of weight loss and treating risk factors, we have medicines like GLP-1 receptor agonists or combination GLP-1, GIPs, etc. So obviously, when those patients with advanced liver disease, we want to choose what we're going to be given appropriately. When we come over to the idea of treating the underlying conditions like diabetes, if it's something that hyperglycemia predominates, or there's CV risk factors, something that needs to be addressed, we want to make sure that we're considering agents first in line for handling all this would still be GLP-1s. Or maybe even SGLT2s. Antihypertensive treatment should be managed, or antihypertensive management should be instituted, and we should be treating high blood pressure. Dyslipidemia is definitely something else that cannot be overlooked. And as this asterisk on the top right of this slide shows, we don't want to withhold or avoid statin-based treatment based on risk of or past concerns of drug-induced liver injury or abnormal liver enzymes. And then for liver-directed treatment, we have one labeled in red here. Resmetirom is approved for MASH specifically, and then we have some other data-driven recommendations like vitamin E and Pioglitazone. We'll talk about these a little bit more. So if we just, to kind of get familiar a little bit with GLP-1 receptor agonists, GLPs, GLP-1s, if you don't already know, or if there's some confusion for patients and providers alike, our body already makes GLP-1. Like, this is an endogenous or a normal peptide that's secreted. So an agonist is going to be something that we give as analogs to kind of improve or enhance the effects of the normally occurring endogenous GLP-1. GLP-1, what it does when it's active and it's been secreted generally by the intestine, the jejunum, the terminal ileum and first part of the colon, as well as maybe some of the duodenum. But it's going to stimulate your glucose-dependent insulin secretion from the pancreatic beta cells. It's going to suppress glucagon production or release, also from liver and pancreas excess. We know it actually has kind of this negative feedback loop where it's going to delay gastric emptying, and therefore it actually will start to decrease GLP-1 once you feel full and kind of the food is slowing down, and then it directly acts on the brain and the hypothalamus to promote satiety, feeling full and satisfied with hunger, and also will reduce the energy intake of the brain, and we can see this in other neurocognitive type diseases, as well as maybe GLP-1s have a role. As mentioned, they are analogs of kind of this GLP-1 is an incretin hormone, is kind of the class that it falls under, and we know that with all this, it can definitely, and it's been shown now for many years, they can lower blood glucose and cause weight loss with GLP-1s, GLP-RAs or receptor agonists, be on the market for now over 20, 25 years. In hepatology, it's not something that, it's not that we use these historically in hepatology practices, but with more and more data coming out on the role and the effect of specific GLP-1s, I think this is something maybe my colleagues and whoever's listening may agree that this is becoming more and more in our domain as hepatology practitioners. Recently in this past year, there's been data that Semaglutide, a 2.4 milligram once weekly dose, did meet trial endpoint data of histology nature. So at 72 weeks, we're looking for both or either or MASH resolution without worsening fibrosis, or improvement in liver fibrosis without any worsening of MASH. And you can see that the treatment versus the placebo, it was effective, and the data is this is something that may change label and how we think about these medications. Specifically, clinically speaking, for those that are overweight, obese, they have the hyperglycemia risk or diabetes. Whether or not we want to use this in someone with lean MASH or normal body weight, we got to look at then kind of the known adverse effects or kind of the effects of a GLP-1, because this is going to not only without good nutrition and exercise components with this, we can actually lose more than just the adipose and the fat tissue. There can be muscle loss. One other known effect, and probably the biggest adverse effect that may limit patients' ability to kind of maintain and stay on the dose you'd like them to be on, will be the effect on the GI tract, specifically the delayed gastric emptying. From a GI standpoint, and those that perform endoscopy type procedures or any type of anesthesia services, we worry that there can be delayed emptying leading to reflux, higher pressures, and then risk of aspiration. There's back and forth, best recommendations on when should a GLP-1 be held or stopped going into an endoscopic procedure like an EGD or a colonoscopy. It really has to do primarily with the anesthesia and the aspiration risk. I'm sure by the time the end of this year rolls around, we may have other guidance on this, but definitely holding a weekly dose of a medicine for one dose generally is not anything that's going to negatively impact the patient, and if it's going to improve safety, then of course we want to take that into consideration. Switching from GLP-1, specifically Semaglutide with the data, and there's others out there, but we've had data for a long time on vitamin E, specifically a dose of 800 international units daily, and this is specifically was looked at in the Pivens trial, which kind of looked at vitamin E and Pioglitazone, which will be on the next slide. In those patients with MASH without cirrhosis and without diabetes, there was some some weak improvement on histologic outcomes and evidence of the MASH, not necessarily fibrosis. Kind of the role of vitamin E as an antioxidant affecting the inflammatory nature of what we see in fatty liver with inflammation and true MASH. There are, obviously in the study and then just with known effect of vitamin E, not all patients may respond, and we want to be mindful with certain patients that are maybe hypertensive or poorly controlled diabetic. Based on guidelines here in the U.S. and specifically the AASLD, we still suggest as vitamin E as an option for non-diabetic, non-cirrhotic MASH now, not NASH, and then kind of throughout the world and Europe, they don't really recommend it based on the fact that it doesn't have great effect on fibrosis, and there's some risks, and those risks could include some bleeding, some long-term chance of prostate cancer, and there's some other cardiovascular outcomes that's debatable, and we really just don't know how long would we really use vitamin E. Is this a short-term antioxidant to improve inflammation, or is this something that someone should be on lifelong or for multiple years? And that data just isn't available. But it is an option here in the U.S. It's a consideration, especially for patients who may not want to be on something more formally, a formal medication. This is over the counter, so that may be a pro in that setting. Kind of the other side of the Pivens trial was the Pioglitazone. We know it also, in kind of the class as a PPAR agonist, dose of 30 to 45 milligrams a day. This can be used in patients with or without diabetes as well. And obviously there's more of an anti-hyperglycemic effect with Pioglitazone, and therefore you'd imagine from a diabetes standpoint, better control, maybe better aspect of MASH, but there really was no significant benefit on histology on this. It was more secondary outcomes with cardiovascular risk reduction, diabetes, secondary risk. So makes sense, better control, but specifically for liver, kind of weak. And there are definitely some safety considerations with the medication in the class, specifically weight gain and edema, and then in women maybe bone-related issues. There's been kind of a question of is there an increased risk of bladder cancer, and that's something that should be informed of the patient before making careful decision making and getting that informed decision. Now, most notably in recent in the treatment of MASH and MASLD, we know over a year ago Resmetirom was given conditional FDA approval to be prescribed to those patients with MASH or NASH with F2 to F3 fibrosis, and it is to be prescribed in conjunction with diet and exercise. So jokingly, don't just take the medicine and eat and drink what you like and don't exercise. This still should be with the lifestyle modifications to maximize and optimize the outcome. The class and the kind of the mechanism, this medicine, it's an oral agent. It's a thyroid hormone receptor beta agonist, so very selective receptors in the liver that your thyroid hormone will hit. It binds to it, it activates it, and therefore kind of causes this cascade of effect to improve the liver. So kind of a more physical cartoon or drawing. Let's see. Oops. TSH, thyroid stimulating hormone, and this feedback with kind of the central axis and the effect on T4, T3. But we do know that there's thyroid receptor alpha and beta, and the beta cell and the beta receptors are specifically liver located. So what it kind of helps improve is it will decrease and improve the fatty acid oxidation. It increases different enzymes in the liver like PPAR, SRBF1C, decrease some other factors that ultimately reduces and melts away the fat more rapidly. And we know the data shows that even in 12 months, MASH resolution without worsening of fibrosis and/or fibrosis improvement without worsening of MASH was statistically significant over placebo. This was through the MAESTRO-NASH trial, which is still ongoing. Over 800 patients were part of this study. Patients, F1 to F3. There were really 3 arms, so 80 milligram arm, 100 milligram arm, and a placebo arm. And at that week 52 or that 1 year, the efficacy outcomes of NASH resolution and/or no worsening of fibrosis was what was looked at. And just from now that it's been out on the market for a year, we know, not only from the study, but maybe real world data, but Resmetirom does have some known AEs or adverse effects or just known risks of diarrhea and nausea that was more frequent or more readily seen than the placebo group. Anything serious, however, was very similar across all groups. And this graph here shows you, from diarrhea from a placebo in the dark color, Resmetirom 80 in orange, Resmetirom 100 in gray. Kind of diarrhea was dose dependent, if you will. Nausea slightly increased in the Resmetirom arms, but serious adverse events all the way to the right was equal and similar across all groups. We know, and going back to the kind of the superiority over placebo, so for NASH resolution with no worsening of fibrosis, both the 80 milligram and the 100 milligram arm achieved 26 to 30% primary endpoint versus almost 10% in the placebo. And then for those that actually had fibrosis improvement by at least 1 stage, equal or greater than 1 stage, with no worsening of what we call the NAFLD activity score or histologic findings of active MASH, we can see 24 to 26% 80 to 100 milligram dose arm compared to maybe 14% in the placebo. So this also is statistically significant. And there's been a lot of meta-analysis and kind of looking at the data from different angles, and we can see based on dropout and other aspects that maybe the effect is even more than this. And I think just speaking on primary endpoint at 1 year versus as the study continues out even further, month 54 and maybe beyond, we're looking at long-term efficacy and long-term results with these endpoints: NASH resolution, fibrosis improvement. So just kind of practically speaking, for patients with Resmetirom, who are the ideal patients that you should identify? Definitely those that are not cirrhotic, whether compensated or decompensated. This was not the population that the study was looking for, and those patients that do have cirrhosis by any means really should not be a candidate for Resmetirom. F2 to F3, but based on either non-invasive tests or maybe liver biopsy, depending on current insurance, current center that you're at, or just means of access. As it comments, it's only approved in conjunction with diet and exercise. I don't think only is appropriate to say specifically, but that is kind of the idea when you're educating patients and you're prescribing this, that it is to be met with diet and exercise. Ideally, they've already been doing that to some extent before the prescription goes through as well. When you're on Resmetirom or about to start it, there are some maybe have some awareness on the drug interactions with other maybe fairly common medicines. Really, there's only a few medicines that are actively seen in clinical practice for most of us that should be totally avoided, and that's going to be on this column to the left. These are going to be your strong TC8 or the OP1B1 3 inhibitors. Gemfibrozil is one most mentioned, but I would even point out things like clarithromycin, lucilimide, for example. These are medicines that you'll still see in practice. Patients that are on clopidogrel, trimethoprim, there should be some maybe dose reduction in the resmetirom. There are 80 milligram and 100 milligram prescriptions based on weight. However, there's also 60 milligram formulation that if someone is on clopidogrel when they should be on 80, then you may want to reduce that. And then specifically other medicines that might need to be modified. We know that some medicines may actually have an increased availability or exposure due to resmetirom. So if they're on it, that may be something where the dose of that increases. Things like pioglitazone, which we've already discussed today, would be something that you shouldn't be on a very high dose if you're going to be starting on resmetirom. And then with your statins specifically, we know that high dose of statins is not really ideal. So this gives a good overview on max doses allowed for your, both some of your water soluble and fat soluble statins, atorvastatin, rosuvastatin, pravastatin, simvastatin. So 20 to 40 depending on which statin we're talking about. Further, just practically speaking, once you're on the treatment, if the trial was a 1 year long, outcome and endpoint of histology findings, we would think that this is going to be something that is going to be at least 1 year of treatment for a patient if they can tolerate and there's no issues. And until we get further information and the data is available from the MAESTRO-NASH trial, but we at some point, we want to see if the patient is responding. We should be relooking at either non-invasive tests like the FibroScan, BCTE, vibration-controlled transient elastography, on MRI, measuring the proton density, fat fraction, PDFF, seeing if there's actually fat reduction, which this would be the gold standard test. Alternatively, we could use the CAP on a FibroScan that is a good estimate of fat in the liver as well. Maybe the enhanced liver fibrosis blood biomarker, which is a blood-based fibrosis score. These things can be, used, and there's been some guidance on what to consider for, response versus non-response versus maybe partial response, if I use that term appropriately. And then just kind of how often and frequency of testing. There's been some recommendations, and that may change, and your own individual practice may vary, but we do know that it's not something that you need to be doing this super frequent or all the time during treatment. We're talking maybe at earliest every 3 to 6 months for some of this, but even 12 months for things like an MRI PDFF or even a FibroScan could be something to consider after 1 year of treatment, just from personal experience and data. There are still some questions that remain, as far as coverage and accessibility, although this has been a good year of learning how coverage will go for resmetirom. The staging, lab tests, the monitoring plan that, as we mentioned, is still kind of looked at, and if we get more data behind that, we can, experts can provide those recommendations. The when to discontinue treatment, that kind of goes in line with that, and that's a good question. But ultimately, if a subject patient is still with fibrosis and/or MASH, maybe they've improved but not resolved, do we continue treatment? Again, that's a topic of ongoing discussion. And then just the other aspect to know is, and where I practice in clinical research, we have other multiple agents currently being evaluated for MASH and MASLD. And at some point, if these get approved, we may have more than one direct liver agent for MASLD MASH? What about in conjunction, or is there going to be some sort of stepwise approach where you try one and then the next? So all this is very exciting, but a very much changing landscape on how we will manage MASH with pharmacology and pharmacotherapy options. And I appreciate your time, and I hope this was very informative, and thank you for allowing me this opportunity. Have a great day.